Morning, Tim. Thank you so much for joining me today. Why don't you take a moment and introduce yourself?
Happy to. Thank you for inviting me to talk about psychiatry. My name is Tim Kreider. I am a psychiatrist at Zucker Hillside Hospital. I treat ambulatory patients, young adults, college students exclusively as part of our BHCP, our college program, one of our subspecializations of our clinic, large clinic at Zucker Hillside Hospital. I also am the director for undergraduate medical education for psychiatry, which means I support the ACE director and the human conditions co-director. I was formerly the ACE director in psychiatry for 5 years. And finally, I am an associate program director for the residency in general psychiatry at Zucker Hillside Hospital.
Well, thank you so much for your time. I appreciate it. I wanted to talk a little bit about you and your own path to psychiatry.
Oh, for sure. In psychiatry, I find there are two types of future psychiatrists: the ones who know it
Yeah.
from like undergrad or earlier, and then the ones who discover it to their surprise. And I was the latter. I was so excited to be ACE director because it was my clerkship when I discovered psychiatry. I even have a memory of day one assuming that I wouldn't like psychiatry
Hmm.
and just floored by the end of the first week. So impressed. It was the combination of head and heart for me, right? Like I found it so intriguing. I was so curious to learn more about how the brain creates the functions of the mind that we were seeing go awry in these patients. And also, I was just filled with compassion for these patients. I find a lot of medicine, picking your specialty is like, what type of suffering can you tolerate being near and be motivated to help alleviate? And to my surprise, I found that like emotional distress really moved me, and I was better at it than I had expected. In psychiatry, we 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 take all types. I like to say from poets to physicists. And that's increasingly true nowadays because we've got more and more sort of neuromodulation type interventions and research on the brain. I was initially a math major and then an MD PhD student in an immunology lab. So I thought I was on the physicist side of that spectrum, but I was really taken in by uh, our interventions that involve talking and relating to patients, doing a deep, sensitive interview, psychotherapy, and similar kinds of things. And so now, really, a lot of what I do is about teaching students and residents how to think about patients, how to formulate, how to be therapeutic in their interactions. And so I love that psychiatry is like an eclectic field where we've got everything from just talking to sort of intervening at specific parts of your brain with
Yeah,
TMS.
yeah, the full spectrum. Psychiatry seems really set apart from the other specialties. So, for a lot of students, it seems like something that that might be a little bit more daunting or a student that isn't sure about how they should approach preparing for that day one psychiatry clerkship. What advice would you give them?
So one thing that will challenge you in psychiatry that we pride ourselves on trying to be experts in is interview with patients whose symptoms or style interfere with being a reliable or cooperative partner in co-constructing the the narrative with you. And so you'll encounter patients with psychosis, with mania, with significant personality pathology, with addiction, and these disorders, the symptoms of them can get in the way. One thing I would say to prepare is to, review your textbook and your resources in communication. There are chapters in here on interviewing a patient with a psychiatric presentation. It's in fact written by psychiatrists, um, and so getting ready there. I and getting ready for that, you may have to interrupt a patient in ways that you normally don't. The next thing that we do in psychiatry that every physician needs to do, and increasingly every specialty is doing a much better job relative to when I was in med school, is thinking biopsychosocially about our patient, thinking about uh, social drivers of health, systemic factors that influence health behaviors and outcomes, thinking about how thoughts, feelings, behaviors, relationships in a patient's life affect whether they access care, how they access care, how their illness manifests, how they are able to comply with treatment recommendations, and trying to be holistic in thinking about both the biology of the brain and the body and also the psychology of relationships, environment, and all of that. Psychiatrists have long been the champions of this. And so when you're on Psychiatry ACE, you'll be writing a biopsychosocial formulation. And it's the part of ACE rounds and the write-up that feels the most different to most students relative to the other ACE specialties. But it's really just an extension and an elaboration of what you've been taught all through first 100 weeks about seeing the whole patient, not just the disease, thinking about social drivers, et cetera. So recognizing that it's not wholly different, it's just taking it up a level. And then I think the third thing that maybe students find is different is the way we make diagnoses. And I have another book here. This is the DSM-5. And, it's a good one to have and to reference. You don't need to buy it, of course, as well as I think this book is referenced as well. Oh, here it is. Psychiatric Interview, especially if you think you might go into psychiatry. But even if you're not, it's a small book and it really sort of helps with interviewing for psychiatric diagnosis. I am fond of saying that psychiatry is rheumatology, but without labs. So we're not the only specialty that has diagnoses that are syndromes and collection of a bunch of things that feel a little bit arbitrary. Well, it's 5 of 9, but we have it in spades, and we don't generally have the more objective measures like labs and imaging supporting the diagnosis. Now, of course, we continue to sort of look for that, but the lack of that is what has made us such careful and hopefully skilled interviewers, because really the patient's report, our observations of the patient, and our collection of data from other people in the patient's lives, that's really what we need to gather to make our diagnosis.
Would you say that then that skill is something that psychiatry teaches that you wish every doctor would know?
For sure. I think it's terrific and important that psychiatry is one of the required ACE clerkship experiences because, even though we're interacting with our patients in a different way than you will if you're a physician in another specialty, you can definitely learn and generalize skills you learn in really challenging, emotional, sensitive interviews to be more effective in your contexts. So that's one. And then a second thing is that our patients are your patients. Psychiatric illness or just mental health symptoms or distress, even absent a diagnosis, these are very common. And in fact, they're probably more common in high utilizers of medical and surgical care than the general, more healthy population. So whatever kind of physician you're going to be, you're going to encounter a patient who has your problem and also one of my problems. And so being able to navigate that, to recognize it, to adapt your interaction to that, and when necessary, to intervene or refer is really important for any physician. You might be the first person to find out that someone's having suicidal thoughts. What are you going to do about that? How are you going to talk? How are you going to refer? How are you going to safety plan? And so those are some essential skills I want every student to get out of Psychiatry ACE. And it'll make you feel more confident and comfortable walking into these exam rooms, operating rooms, emergency rooms where you don't know what you're going to get. Patients are going to surprise you. And just like you're ready with your physical exam, you're ready with a trauma-sensitive, self-harm focused safety assessment if needed.
Yes.
I think the way to be a successful student on a team in psychiatry is to be curious about what you're seeing and practice clinical inquiries, evidence-based medicine when you come up against questions about management. And so there are some seminal studies, of course, in psychiatry, and there are treatment guidelines that generally everybody agrees on as the first approach, and you want to get familiar with those. STAR-D, STEP-BD, CATIE are the names of the big trials. Any psychiatrist supervisor can direct you to those. But of course, you're going to see patients. This is common in psychiatry where the first line, second line approach wasn't sufficient. I mean, especially because you're going to be in our acute settings, like the ICUs of psychiatry. So by selection, you're getting folks who, they already tried Prozac at a moderate dose, right? And so very quickly, we end up outside of the standard treatment guidelines. So the first step is to know the guidelines in the first approach. And then the next step is to go look up and try to say, like, for this patient with these comorbidities, these demographics, do we have any evidence to support choosing one agent over another? And preceptors and teams really appreciate it when students go do that kind of homework and come back and share it. You're on academic teams where we're all oriented towards always learning. And whether you find an old classic or a hot off the press new study, that's a great way to help the team support, impress the preceptor, help the patient, the triple win.
Yeah.
And the other thing that I think is important is to just lean in. The students who end up getting pass or high pass are more likely to sort of do what's asked of them and maybe do it very competently, which is great, right? Obviously, if you get a pass, we're saying you are competent.
Yes.
But the students who get honors are more likely to seek out ways to contribute or things to learn. So, for example, on an inpatient psychiatry unit, the team is interdisciplinary. Psychology, rehab, social work. These are different disciplines that will have both individual treatments of patients and group interventions, especially at the group interventions, but also individual, like med students are welcome to observe. And if they observe enough, maybe participate. So, the honor student is one who's more likely to go ask the staff psychologist, may I sit in on this skills group? And after sitting in for a while, hey, would it be, would I be able to try leading the mindfulness activity? We're not going to make you a psychotherapist on a 4-week rotation, right? But you can be curious and you can be learning, and you can learn how we psychiatrists reinforce the interventions of our colleagues in other disciplines in every interaction, right? I'm not doing CBT, but I'm using CBT language when I talk to a patient who's in CBT to reinforce that. And then, of course, things that you would do on any service that are helpful to the team, tracking down collateral, very important in psychiatry, especially acute psychiatry. Maybe outside providers, looking up, doing a chart review. And then finally, there are some parts of the work that other disciplines do that you could learn and help with, like making a safety plan. And that's something that, again, your preceptor might not ask you to do it because that's not, classically in the physician's role in an interdisciplinary team. But that kind of curiosity, help out, learn everything about what the team's doing. That's the way you distinguish yourself, and the way you get the most out of it is a learning experience.
Definitely. You helped us really see what that honor student looks like. Is there anything specific to psychiatry that medical students should avoid doing on their clerkship?
Well, I don't know if this is specific to psychiatry. It's hopefully not, but it maybe is something more fraught, or something to be more mindful of on psychiatry. We treat very vulnerable patients. I would hazard even more so than many other settings, simply because by having significant psychiatric illness, that itself is a stigmatizing vulnerability on top of every other way that our patients may be vulnerable, from social drivers to marginalized identities, et cetera. So, and psychiatry and our patients have a long history of being stigmatized within medicine, even from other physicians and healthcare providers. Now, we're at a pretty enlightened place and time, so I don't experience that in my work at the medical school. But certainly you don't have to go far in time and space to experience that. And so students may come with their own preconceptions, implicit bias, stereotypes that they didn't even realize they had. They're going to be confronted with difficult patient and family behaviors, and it's driven by the pathology and the social circumstances that these patients and family find themselves in. And so we really challenge ourselves to find ways to be compassionate to the least lovable patients, frankly, right? Like the patient who's struggling with addiction, with severe personality pathology that they don't want to have, but they do, with frightening symptoms of psychosis or mania. So the thing to avoid is language or behavior that reinforces stigma of our patients or our discipline. And that doesn't mean you've got to sort of monitor what you say because the wrong word would doom you. I think psychiatrists, maybe more than most physicians, realize that we are just as human as our patients, and we have brains and social drivers too. And so there's a very strong tradition in psychiatry of examining the feelings and thoughts you're having and talking about them, even when you're not proud of them. So the flip side of this is if you notice I'm having this feeling or assumption about a patient, it's safe and it's admired for you to bring it up in a sort of curious way where I notice this. I don't want to act on that. I want to be the best doctor for this patient. And that's another way to really practice like a psychiatrist and impress the psychiatrists on your team.
Yeah, that's so helpful, that like real world example of turning a negative into a positive for sure. So I wanted to ask you, because you've obviously given us so much good advice, what's the best piece of advice you received during your training?
One that really stuck with me and that I repeat often to trainees, especially residents, who are further along in practicing autonomy than students, is never worry alone. And for a resident, a night float or on call alone, this has to do, of course, with like clinical risk and uncertainty, right? Seeking supervision. In our practice, generally, the kind of medicine and psychiatry I like to practice is a team sport, right? And where I collaborate with psychology, with colleagues, get curbside consults or formal consults. Never worry alone. And I think for the student on psychiatry or going through med school generally, that's also good advice because you're going to be worried a lot about how am I doing? Am I in the right place? Am I an imposter? And any worries you have, like I guarantee they're not unique to you. And so find the safe people to share them with, whether that's friends, family, or trusted mentors. Worrying alone makes worries worse. If there's any part of you that is curious or thinks you might benefit from being in some kind of psychotherapy, whether it's for a clear diagnosis or otherwise, there's a long tradition in psychiatry of psychiatrists being in treatment themselves, again, for the sake of understanding yourself better and practicing what we preach, right?
Yes, totally. Well, Tim, thank you so much for taking this time. I really appreciate it.
It's absolutely my pleasure. And I welcome any student who's even thinking about psychiatry to reach out to me.
Thank you.
I advise all our students who are applying in psychiatry, and I love meeting with students who are earlier in their journey.
Wonderful. Thank you so much.